Good morning, everyone. I am Amna from the Department of Optometry and I am going to present on the topic of retina. I hope this presentation will give you a clear understanding about the topic. First of all, retina. The retina is a membranous, light-sensitive coat of the eyeball. It is transparent in life and whitish after the death. The retina is derived from the inner and outer layers of the embryological cup. These two primary layers are loosely adherent across the potential spaces. There are 10 layers of the retina. First one is retinal pigmented epithelium, layer of rods and cones, external limiting membrane, outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, ganglion cell layer, nerve fiber layer, and the 10th one is internal limiting membrane. Next, we are going to discuss about the disease of retina. That is, the first one is Coats disease. Coats disease is a chronic progressive vascular abnormality in which the retinal vessels leaks fluid, which results in an exudative bullous retinal detachment. It usually affects the boys, that is between the age of 18 months to 18 years of age. It is usually a unilateral condition, but both eyes may also sometimes affected. The main symptoms are decreased visual acuity and white pupillary reflex, that is known as leukocoria. Ophthalmoscopically, we can see an yellowish white exudative patches which is seen behind the retinal blood vessels. The retinal bloods have a tortuous course with aneurysms, fusiform dilatations and loop formations. Subsequently, they leads to the detachment of the retina. Retinal detachment with iritis, cataract and glaucoma. The treatment is frequently ineffective in established cases, but in early cases we can give the photocoagulation or cryotherapy. The next one is CRAO, central retinal artery occlusion. The occlusion may affect the central retinal artery itself when the entire retina is involved, or the peripheral branches, which is when the effect is localized. Causes, that is emboli from the carotid artery, emboli from the valvular heart disease, thrombus from arteriosclerosis, hypertension and arthritis. The symptoms are usually painless, unilateral, sudden loss of vision. The second one is amaurosis fugax, that is a transient sudden loss of vision lasting for few minutes due to the occlusion of the minute emboli, may be a premonitory symptom. Signs: ophthalmoscope gives appearance of, that is, the largest arterioles become thread-like and the smaller arterioles are completely invisible. The veins are almost normal. Within a few hours, the retina roses is transparency and becomes opaque, that is milky white in color. A day or 2 days later, a cherry red spot appears at the fovea, which is appearance of the choroid. It is underneath. The vision is no PL and there is no direct pupillary reaction. The diagnosis should be depend upon the history, since the patient is very rarely seen during the acute attack. Treatment: we have to give the immediate intermittent digital massage to the globe. We have to give intravenous acetylzolamide, inhalation of 5% of carbon dioxide and 95% of oxygen mixture for every 10 minutes may be helpful. The paracentesis of the anterior chamber, retrobulbar injection of acetylcholine to produce vasodilatation. As an anticoagulant, we can give as intravenously. Heparin should be administered. Central retinal vein occlusion. The vein occlusion may involve the central retinal vein, which causes the immediate loss of vision, or a branched retinal vein occlusion, which results in the partial loss of vision. Depending on the affected region ranged by the age, predisposing factors, age, that is 6th and 7th decades, which is due to systemic hypertension, due to raised intraocular pressure, for the diabetic patient, it leads to CRVO or CRAO, hyperviscosity syndrome, periphlebitis as in sarcoidosis and Behçet disease. Central retinal vein occlusion may of two types, non-ischemic CRVO and ischemic CRVO. Non-ischemic also refers as venous static retinopathy or partial CRVO. This accounts for 75% of the cases. Next one is ischemic, also called as complete CRVO. This accounts for remaining 25% of the cases. Clinical features in non-ischemic CRVO are that the visual acuity is slightly or moderately reduced. We can see the relative afferent pupillary defects, that is Morgan's gun pupil. Ophthalmoscopes shows that mild tartaricity and dilatation of all the branches of the central retinal vein. Dot and blot and flame-shaped hemorrhages are seen. Cotton wool exudates are usually absent in this condition. Mild to moderate swelling of the optic disc in these conditions. Macular edema sometimes present, sometimes may not be present in these conditions. Prognosis: 50% of the cases the retinopathy resolves and visual acuity returns to normal or near normal if the permanent impairment of vision is due to chronic macular edema. Treatment: no specific treatment. We should treat the predisposing factor if anyone is present. Second one is ischemic CRVO, that is clinical feature shows that marked reduction in visual acuity. RAPD is present. Ophthalmoscope view shows marked tartaricity and engorgement of the retinal veins. Massive superficial and deep hemorrhages are seen throughout all the fundus. That is, all the quadrants of the fundus has massive superficial hemorrhages. Cotton wool exudates are common. Optic disc is swollen and hyperemic. Macular edema and hemorrhages are also present. These appearances commonly collectively known as blood and thunder fundus. Treatment: the patient should follow up closely for rubeosis iris. They can be treated with a pan-retinal photocoagulation which prevents subsequent development of neovascular glaucoma. Next one is branched retinal vein occlusion. It may occur near the optic disc, involves the major quadrants of the retina. It may occur at the periphery crossing an artery. Blockage of the superior temporal vein frequently involves the macula. Symptoms: these depends upon the locations of the occlusion. The visual loss is marks in the superior temporal branch is occluded. Ophthalmoscope shows the dilated tortuous veins, flame-shaped and dot and blot-shaped hemorrhages in the affected quadrant. Retinal edema and cotton wool spot also present in these conditions. Treatment for macular edema: the grid photocoagulation with argon laser or double frequency laser may be helpful. For neovascularization following BRVO, the eye should be treated by scatter argon laser photocoagulation in order to prevent vitreous hemorrhage. ROP, that is retinopathy of prematurity. It is a bilateral abnormality with retinal neovascularization. It occurs some weeks after the birth in premature infants, that is, the weights less than 1500 grams, who has been given high concentration of oxygen during the first 10 days of life. The earliest signs are dilatation of the retinal veins and appears as a hazy white patches in the peripheral retina. This is due to the neovascularization in the retina itself, which happens into the vitreous. This is followed by the development of fibrous tissues, which is eventually proliferate to form a continuous mass against the lens, appearing as a type of pseudo-retinoblastoma. In many cases, the retina gets detached and of course the vision is lost. Treatment: in 80% of the infants, the retinopathy of prematurity will regress spontaneously. The treatment is required if only the definite progressive lesions are noted in the vitreous. The photocoagulation or cryotherapy to ablate the vascular immature retina. Scleral bulking for retinal detachment. Vitamin E should be given to protect the susceptible infants. How to prevent these ROPs? Premature infants of weighing less than 1500 grams who have received oxygen therapy should be screened for retinopathy of prematurity. Once the signs of retinopathy develop, the child should be re-examined for every 3 to 4 months up to the age of 4 years to learn the progress of this disease condition. CSR, that is central serous retinopathy. The central serous retinopathy is characterized by the sudden edema of the macular area, which typically affect the young adult males. Due to the unknown case, it is basically localized retinal detachment and caused by the exudation from the parafoveal or choroidal capillaries. The symptoms are sudden onset of blurring of vision in one eye, black fixed spot at the center of the visual field, that is, the patient will experience a central scotoma at the center of the visual field, and third one is metamorphopsia. The signs include the visual acuity is reduced to 6/9 to 6/18 and often correctable to 6/6 with the weak plus lenses. Why this is due to the elevation of the neurosensory retina, which give rise to a fall acute hypermetropia. Ophthalmoscopically, the macula appears as an oval or dark circle swelling above the size of an optic disc, which is surrounded by the glistering round ring reflex. Through the fundus fluorescent angiography, we should see the smokestack pattern in black patterns in these conditions. Prognosis: 80 to 90% of the cases of CSR undergoes spontaneous resolution and the visual acuity returns to normal or near normal within 4 to 12 weeks. The mild metamorphopsia or micropsia may persist for a long period. 40% of the patients develop recurrence attack. Treatment: in the majority of cases, no treatment is required except the reassurance. The organ laser or double frequency laser YAG photocoagulation to the site of the leakage may be considered in some cases if the CSR is recurrent with a visual loss, if the patient in the fellow eye is permanently reduced due to the previous attacks of CSR, if the duration is more than 4 months in the presence of turbid subretinal fluid. We have to give the organ laser or double YAG laser photocoagulation for these patients. ARMD, that is age-latent macular degeneration or senile macular degeneration. It is a bilateral condition characterized by the formation of subretinal neovascular membranes at the macula. It is one of the leading causes of the blindness in Western world. Histopathologically, the drusen's or retinal pigments in epithelial degeneration and or atrophy, retinal pigmented epithelium and sensory retinal detachments are due to the subretinal hemorrhages. The drusen's, which are known as colloidal bodies, are the most frequent clinical manifestation of aging and are present about 70% of the peoples after the age of the 50 years. The drusen's are classified into hard drusen, soft, diffused and calcified drusen. There are two types of ARMD: non-exudative, that is dry ARMD, exudative, wet ARMD. Non-exudative is the most common type and it is due to the slow and progressive atrophy of the retinal pigmented epithelium and photoreceptors. The progressive loss of vision for several months to years. Clinically, it appears as a sharp circumscribed areas of retinal pigmented epithelium atrophy with varying degrees of loss and choriocapillaries. Treatment: there is no effective treatment in this condition. We can go for lesions. The second one is exudative ARMD. It is also sometimes referred as a neovascular or wet ARMD. This is more serious form and the patient may lose all the central vision within a few weeks. Two important features of exudative ARMD are detachment of retinal pigmented epithelium and choroidal neovascularization. The retinal pigmented epithelium detachment appears as sharply circumscribed dome-shaped elevations with ophthalmoscope. The subretinal neovascular membranes consist of proliferations of fibrovascular tissues begins to grow from choriocapillaries. Sequelae of exudative ARMD, that is hemorrhages of retinal RPE, hemorrhagic detachment of the neurosensory retina, vitreous hemorrhage, deciform scarring of the macula and exudative retinal detachment. Treatment: we should give the organ laser photocoagulations in effective for many patients. Then we should give the transpupillary thermotherapy TTT and finally photodynamic therapy with the latest treatment for the exudative ARMD. RP, retinitis pigmentosa. This is a conditions. It's a group of hereditary conditions characterized by the night blindness and constricted visual fields. Typical retinitis pigmentosa is due to autosomal recessive, most common autosomal dominant benignature. It is an X-linked recessive condition. The pathogenesis, it causes the degeneration of the rods and cones, migration of pigments into the retina. Degenerated ganglion cells and the axons are replaced by the neurological tissue. The attenuation of the blood vessels, atrophy of the optic disc. Clinical features, symptoms include night blindness and progressive visual field defect. Signs are bony spical formations, arteriolar attenuations, and waxy pallor of the optic disc. It causes the macular lesion, that is cystoid macular edema, cell phone maculopathy, and atrophic maculopathy. Investigation: in this condition, we should go for the ERG, EOG, and visual field evaluation. Initially, the patient shows the annular or ring-like scotoma, but when the visual fields leave tiny islands of central vision which may not be lost eventually. Treatment: no treatment is effective except we can go for low vision aids. Thank you.